Switch to the handheld here. All right. Good morning. I'm Hope Kerwin with Wisconsin Public Radio, and I'd like to welcome you to the second annual Agnes W.H. Science Symposium. Today's event will focus on who is being left behind in healthcare. In the last century, there have been numerous scientific breakthroughs that have led to less disease and longer lifespans. But unfortunately, not everyone has benefited from these advancements equally, both here in the US and around the world. There continue to be substantial gaps in health outcomes based on socioeconomic status, race or ethnicity, gender, and more. As we witnessed during the COVID-19 pandemic, some communities experienced significantly worse outcomes than the overall US population. Today, we're here to learn where these gaps exist in the healthcare system and how we can shrink them moving forward. I'd like to introduce Jamie O'Neill, STEM event planner and outreach coordinator for Viterbo University. She'll share more about today's event.
I am really grateful that you're here today. We start planning events like this a year in advance. So last September, when our committee got together, we started thinking of probable topics that might be interesting in a science symposium and relevant to our community. We made a list and sent it out to our science students and had them rank them. Medicine and ethics came up to be the top one by far. We started narrowing it down a bit from medicine and ethics, and while we were in a committee meeting, we had a past Viterbo student come by and say, he's a pharmacist here locally, and he said, one thing I wish I would have known more about was health disparities and health gaps, because that's something I see every day in my work. So I'm hoping that while you're here today, you'll learn something that will help you with future research or help you in jobs that you will continue to do or do in the future. This symposium was made possible due to a gift from Agnes Tan. She's an alumna from Viterbo University, and she used her talents in biology and chemistry to do many things. One of them, conduct research at a hospital, which is why I think she would have really liked this symposium today. She became acquainted with Viterbo University through Franciscan sisters that came to her hometown in China. She was an international student, and after graduating from Viterbo, went on to earn a PhD in biochemistry and do amazing work. Because of her gift, we're able to have the symposium free to participants. And today, our participants, we have over 400 pre-registered. Yeah, you can clap, that's great. 90 of you said you would join us in person, and 10% of you are joining us online. 60% are from Viterbo, 40% are from our larger community. Some of you are representing booths throughout the day, and some of you are speakers. Welcome to all.
Now I'd like to welcome this morning's keynote speaker. Dr. Tanisha King is an author, international speaker, and consultant. She currently serves as the Chief Inclusion Officer for the Heritage College of Osteopathic Medicine at Ohio University, where she is also an adjunct professor in the Department of Social Medicine. She also teaches a PhD-level social change course at Southern New Hampshire University. A three-time alumna of the University of Illinois at Urbana-Champaign, Dr. King previously taught at the undergraduate and graduate levels at the U of I and at Fordham University. She's also serves her community through volunteerism as members of various boards of directors. Dr. King has been featured in multiple news and radio outlets and appeared in the 2017 Virginia Theater performance, That's What She Said. Her first book, Out of Battle into Freedom, was featured at an NAACP author pavilion and has been described on Amazon as a must-read. She's the founder of Dr. King Speaks, where she helps organizations move from performative to transformative diversity, equity, and inclusion practices, and empowers women to overcome obstacles through radical self-love. Her podcast, Ask Me How I Know, discusses politics, social justice, women empowerment, and more. Let's welcome Dr. Tanisha King.
Okay? Excellent. So happy to be here with you this morning talking about the roots of Black maternal mortality. I will first give a trigger warning that this will be explicit content, that the things that we discuss today may trigger you. What I want you to remember as you listen today, to not confuse trigger with discomfort. Some things may make you uncomfortable. Depending on what your lived experiences are, what access and exposure you've had to the topic, you may be uncomfortable. If you've had particular experiences and lived experiences that resonate with you today, I want you to take care of yourself if you're triggered. Feel free to leave the room and come back in when you're ready and prepared. But again, feel free to sit in the discomfort. Why am I feeling what I'm feeling based on what I'm hearing? The trigger warning. The images that you see on the screen, the words of our history in the United States of America. Very things that we were founded on that continue to be perpetuated in our society that really resonate and overlap with the health disparities that we see in our country. When we look at these things, genocide, the murdering of people based on their origin, makeup, and group and ethnicity, slavery, where you were captured and put in chains and made to not have freedom. When we look at some of these things today and how they overlap with what's happening in our world, we can see that that was the foundation. Why, Dr. King, would you talk about slavery? It happened so long ago. None of us were there. We didn't create slavery, nor did we create racism. And this is true. However, we all have a responsibility to address it because we see the roots of these very heinous activities and events continuing to be perpetuated in society today. There are many ways that we see the residue of these things happening, but unfortunately, and far too often, we choose to sweep it under the rug. The pile is really high. And I think as a nation and society, when we choose to lean into the things of the past, it will help us move forward in the present. When we think about how our society was founded, the things that we're proud of and not so proud of, how are those things talked about in your lives, in your world? The way in which we were socialized, unfortunately, still stem from those same foundational roots that occurred heinously in our world. So in your space, were you taught about those histories? And if you were taught them, how were they welcomed? How were they reinforced? How were your values, ideologies, and beliefs founded upon? I'm reminded of the movie American History X, if folks have engaged in that film. It tells a story of two young white men who had a white male father who sparked racist ideology and KKK mentality. These two young men, as they attempted to navigate the world, adopted a lot of that socialization and ideology from their father. And as they went on their journey attempting to refute what he was saying, they adopted it and then went on and did heinous things to underrepresented minority people, including murdering and slaying them in the streets. It is the power of that socialization process and the power of who we learn from and what we choose to adopt that helps us understand the world and how we treat other people. Imagine loving and respecting your father. Maybe many of us do, depending on who your family is. You might not care for that, but you might love and respect them. And so you're going to choose to take what they say at face value, right? And then you adopt that and internalize it into the world. And so attempting to minimize that conversation with your father or not adopt it would be really difficult, right? I liken it to waking up and exercising every morning, which I should do, and as physicians and future nurses, you would probably encourage that, but I don't always do it because it's really difficult, because it's about mindset. Just think about the way in which we're socialized in the world and how that has made up our minds. Far too often, we don't get to sit and think about how we become who we are. Why do I think what I think? Who did I get that from, right? And how does that really resonate with me and who I am at my core? When we think about these socialization processes from the first beginning in your home, how did you grow up? Did you have a two-parent household? These things shape our lived experiences. The institutions that we affiliate with, what type of schools did we go to? What did our church teach us about the LGBTQI+ community? And do I believe that, or did I adopt it based on the way in which I was socialized? How do we move from this foundation of our world and how we were founded and how we see this perpetuated today? How we've kind of been socialized to look at the world. How does that really show itself up in everyday life? It's nowhere near as blatant as it used to be. So when you point to slavery and genocide and colonialism and these heinous things that happened in our world, you can be very specific and you know when it happened and what happened. In today's world, though, it's much more subtle. It comes in the form of microaggressions. Microaggressions was coined in 1978 by Dr. Chester Pierce, an African-American psychiatrist. He wanted to give notion to what he was witnessing his Black colleagues go through in the workspace. And so he labeled it kind of subtle offenses and insults towards Black folks, right? And then in 2007 and 2010, Dr. D. Rawd Wing Sue and his colleagues decided to broaden this notion in terms of microaggressions and make it more than just about Black people, but about marginalized and oppressed groups overall, which I think is a good move to make, because oppression is oppression is oppression, right? If I'm oppressed, you are oppressed, so on and so forth. And so he broadened the term to ensure that we know that it's not just Black people that experience this. It's people with different disabilities. It's people with different accessibility issues. There are people in healthcare and women that are seen as just nurses and not the doctor or physician in the room, right? These notions and language are based on the ideologies that our world has socialized us into believing. And sometimes it comes off as compliments. Right? How often did I get in graduate school, you speak so well, you're so articulate? Well, I'm educated, I would hope so. What would make you give me that compliment? Is it this notion of this stereotype of who I am as a Black woman? And would you say that to a white colleague? Right? And so assuming these things about people are rooted really in the foundation of our world. Our ideologies, the way that we were socialized, has made us believe particular things about people, and that comes out in everyday life as these insults. Why does it matter? Why is it important? The old notion of sticks and stones may break my bones, but words will never hurt me, but words do hurt. And it's important because the way in which we were socialized helps develop these identities and how we treat other people. And it comes down to this rooted ideology of this individualism, denying racism, denying that I am indeed sexist and or racist, when indeed we all are, because of how our world and society was founded. The way in which things are perpetuated today, the way that we were socialized, we all have made mistakes as it comes to this work, but we often choose to deny that it exists within us, which really stops us from progressing towards where we're trying to go. It's always really nice to not spew racist ideology directly, but it's really different when it's subtle and embedded in our institutions and we're not choosing to use voice to speak to the discrepancies that we see. And that's the difference between non-racist and anti-racist. So let's think about that too. Am I non-racist or anti-racist? Non-racist is choosing not to spew the ideology. Anti-racist is actively fighting against it daily and not denying that I'm not a part of the problem, that from time to time I perpetuate these very things. I've been doing diversity work for quite a while and I still make mistakes. And I will continue to make mistakes because I'm a human being. And once we choose to adopt that cultural humility of who we are and decide to move on, because it's not necessarily about us, it's about the people and the health disparities and the things being impacted by them. So again, why is it important? Sticks and stones may break my bones. You mistook me for a nurse. You told me I speak well. Why does that matter? Can these things, ideologies, values, and beliefs result in much dire consequences? Can microaggressions and these subtle forms of ism result in death. Let's take a look. Beyond microaggressions, beyond just the words, beyond the values and ideologies that you have in your mind, how does this come out and move from thinking and feelings and attitudes to behavior? Because the behavior is the important part. How do we see this playing out in our world? The deaths of the people that you see on the screen, there was ideologies rooted from the way in which people were socialized to think about that particular group of people. The way in which we were socialized, it was decided that they were up to no good, they were criminals, they were dangerous, they were untrustworthy, angry Black women, and then systemically additional things that justify potential racist acts. So it's not just out of the blue. It didn't just happen. They're rooted in the foundation of our society that continues to be perpetuated through the way in which we have been socialized. Dr. King, so what? What are you talking about? We're at this Health Equity Symposium. Where's the health at, right? When we think about the way in which we were socialized and these ideologies and values and beliefs that you have, when a Black woman enters your space to be cared for, there are historical and generational factors that are going to impact the care that you provide based on these ideologies and this socialization that we've been a part of. Historically, rooted specifically in slavery, the Black woman was always touted as physiologically and psychologically stronger than her white female counterparts. These notions was passed on to her through ensuring that she did just as much field work and labor. It was passed on through heinous activity and experiments that were done on her without anesthesia. And you've heard of the Dr. Marion Sims, right, who was technically the founder of modern gynecology, was said allegedly to experience his work on Black female slaves and not give them anesthesia. And then these things kind of carried on in medicine as notions of who could feel pain and who couldn't feel pain, and is your skin thicker than people who have lighter skin. And that impacted the way in which you care because your mentality, mindset, values, and ideology told you this thing about this particular group of people. And often the scariest part is that it's unconscious because of how great we've embedded this socialization process. And that turns into this generational factor in terms of who the Black woman is and how she carries everything on her shoulder, right? The research, when we talk about this ideology and value of the Black woman and the experience, specifically with maternal mortality, these are the rates. This is the disparities racially for pregnancy-related deaths. Black women are 3 times more likely to die in childbirth than their white counterparts. And I'm not sure the other research that likely says it's about access to care. Yes, that's a part of it. It's about the choice to get the care and the jobs that you have and so on and so forth, but it's also about the treatment and the behavior of the care that that person is getting, because the person that may be caring for them may have these roots in that socialization process and these values and beliefs that are unconsciously there. Where else do we see this? We see this in the healthcare experience of even Serena Williams, if anyone is familiar with that story. Serena Williams is a famous, rich, wealthy tennis player, and she went into labor. She was known to have a history of blood clots, and she attempted to let people know what was going on with her body. Not feeling well, right? She's asking for additional care. She was dismissed and unheard and said, no, that's normal. You just had a baby. So, right, they made her feel like she was crazy making, that's not true. She had to fight for her life, even as a rich, wealthy, famous person. The unconscious thing that I'm certain happened in that space was rooted in the socialization process and unconscious thoughts of who Black women were. You're strong, right? You got it. There's nothing actually wrong, and dismissing that, and she had to fight for her life and advocate for herself and had a near-death experience. So the Black maternal mortality rate obviously crosses wealth, it crosses famousness, right? And if Serena Williams had that experience, what luck does a woman growing up in the South Side of Chicago, for instance, have in this system? When we think to present day, or maybe not so present, if folks are familiar with the Kardashian sisters, maybe Kardashian sisters and people that are running out getting BBLs, I forget what it stands for, but you're probably privy to that. There's so much of our culture that is stemming from how Black women move, how Black women dress, the shapes and bodies of Black women that go from wanting the rhythm but not the blues. The blues is actually listening and advocating for me in these spaces so that I might live, and not just taking on the good parts that are cool and nice in the moment. So what do we do about this, right? You talk about this foundational history, we're socialized, and a lot of it is unconscious. So how could I technically move in order to make sure that these things don't continue to be perpetuated? There's 3 ways. On the individual level, which for me is the most important level, right? We always feel like there's nothing we can do. We didn't create racism. How am I supposed to stop something that is so powerful and invasive, right? It doesn't really feel like I can do anything about it, but you can. We're going to empower each other today to say that you do have power and authority. There's privilege in one way or another in your education. There's privilege in your access to people. There's privilege in your networks. There's privilege sometimes in your skin color. There's privilege in your voice and seat at the table for who and what you choose to advocate for. So what you want to do on an individual level is raise your consciousness. You're here today. Self-awareness, right? Being aware of the things that are occurring in the world that may not be your truth, right? I think far so often as a society, if it doesn't happen to us or we didn't see it, it doesn't exist. There are many truths, and the truth behind the lived experiences of Black women are in depth. And so you want to take an account of what this looks like, increase your educational levels relative to that, and really take an onus of what are my own biases. We all have biases. Before last year, I did not include the transcript of my PowerPoints as I spoke, right? To ensure that accessibility for deaf and hard of hearing was there. I just did that last year, but I've been doing this work for 20 years. Huge mistake. Got called out, got an email, hey, right? Can you make this more accessible? Absolutely, right? Modeling cultural humility. I will change that. I did not get defensive. I did not choose to say, who are you to speak to me like that as the expert and tell me what to do? I said, I apologize, that is absolutely not okay. You should not have even had to say that to me. I will make that change immediately. And then we chose to make that change college-wide, not just for my own PowerPoints, but for everyone. But my privilege as a seeing, hearing individual that doesn't have deficits in that area didn't allow me to see that that would be a problem because I was only operating out of my own lens. So step into the shoes and the world of other people in order to really understand their truth and lived experiences. Be an advocate and an ally, right? And there's a difference. Being an ally is kind of like the non-racism. It's like not spewing hatred things and kind of supporting the colleague that was just offended in the meeting. You go to her after the meeting at the water cooler. I cannot believe that they just said that to you, right? And that's that behind the scenes support. We know that it happens, she's nodding, right? But you want to support in real time. You want to be the voice, you want to make a sacrifice, moving from allyship and talking at the water cooler to actually using your voice at the table. I'm reminded of Bree Newsom, who climbed the pole to take down a flag. There was a police call, obviously, to get her from the pole. They were going to choose to tase the pole in order to remove her, which obviously could have resulted in some dire consequences. There was a white man walking by and saw her on the pole and saw the police. He decided, and Bree didn't know him, she didn't know who he was, but he decided to go put his hand on the pole. Why would he do that? He doesn't know her, but he recognized his privilege. And this is more of an extreme example. I'm not saying put yourself in harm's way every day, but I am saying there's a difference between allyship, advocacy, and being a co-conspirator. A co-conspirator chooses to engage and to sacrifice and to stand up and take on the issues that they see their fellow colleagues going through. So on the individual level, that self-awareness, enhancing your education, and choosing between allyship and co-conspiratorship. On the meso level, organizationally, you want to take a look at your policies, practices, procedures. How are we training and teaching and educating our students? What old ways that came from that foundation and history of the United States are we still operating in? There are tests that are still being used in the medical world that are extremely outdated and extremely biased towards underrepresented patients and women. Just because nationally or AAPOM or AAMC hasn't decided to change those things doesn't necessarily mean we have to teach it that way, right? We're in charge of our own curriculum. Let's look at how we are engaging in the work and how we can interrupt that in present day. On a larger scale, right, looking at what laws are being rectified, what senators can we call relative to the things that you are passionate about in terms of the work that we're doing to combat these health disparities overall. I'm reminded of Chinese philosopher Lao Tzu's words, which are very critical to the values that we hold and how we were socialized in our world. Watch your thoughts, they become words. Watch your words, they become actions. Watch your actions, they become habits. Watch your habits, they become your character. And watch your character, it becomes your destiny. When we get into the health field and the work that you want to do, what is your destiny? Who are you committed to? How will you do no harm? How does that harm push up against the values, beliefs, and ideologies that you hold? Where does one begin and one end in those values and ideologies and caring for patients? When we look at the discrepancies and disparities specifically around Black maternal mortality, how will you save Black mothers? What will your commitment to that look like? The references are here on the screen for you. And that's my information. Should you choose to want to listen to anything else, I have to say, if I didn't kind of snatch your edges a little bit more today, you might want to give me a follow. And I'm here for Q&A.
Thank you, Tanisha. Thank you, Tanisha. Hello? Okay. Thank you, Tanisha, for the powerful message. We'll now take questions from the audience. So please raise your hand if you have a question, and I'll repeat your question. So for Dr. King. Who will be the first? Well, I have a question for Dr. King. I'll kick it off for us. As we think about, these gaps in health outcomes, how do we center the voices of the people in marginalized communities who are most affected by them as we look for solutions?
Yeah, so we don't come up with the solutions on our own. We don't decide what we think is best for them based on what we know. We bring them to the table and we have conversations with them. We look at what the statistics are and what they say. We lean into welcoming on any committees that we already have community members into that space, right? Today, we know that more than just students and faculty and staff are here, but that community members are also present. Continue to do that work because the work that we're doing is for the people that are out there, but the people are often not at the table. So that might be community surveys, that might be focus groups, and actually take what we learn to impact change. And looking at the discussions that you have and what they say they want and what they need, and keeping up with the trends, it changes, right? Fairly often, but making sure the voices is represented and that you're not being the voice for someone else, because people are not voiceless, they are just often unheard. So listen to what they have to say and what their solutions are and attempt to move in that direction.
Anyone else? Yeah, right here. And I'm just trying to think through, as you've kind of gone through this over time, whether or not sort of the building blocks that students need have changed, because we're letting
changes and our society has changed a lot. And as you're talking about going from like overt racism to microaggressions, and it can be a really challenging conversation to get people sort of to their whatever their next step is.
Yeah.
I'm just wondering best practices and just how you've seen it change.
That's a $1 million question.
Yeah, I'll jump in and repeat it for those online. So the question is, the question is, working with kind of the future generations of people working in healthcare, have kind of what students need changed over time. How have best practices evolved over time?
Yeah. So again, $1 million question. There are a myriad of different factors there, right? You're taking into account different generational things that are occurring from Gen Z to Gen X to millennials and what that kind of learning style is. But you're also looking at students that are way more active and are activists and advocates that we've ever seen in the forefront. They've always been there, right? College campuses have been the foundation of a lot of marches, protests, and change. However, we're seeing in the forefront the knowledge that students have, all students, regardless of their underrepresented status, right? Becoming advocates and allies in the spaces, and that want to see the change immediately. right now. So this immediate gratification that occurs, but I think that immediate gratification is there because of this history, because of how long we've been seeing the same thing repeat itself over and over and over again. That can be really exhausting because we're like, hey, we know what the problem is. Why does it still exist? Why can't we fix and overturn this today? So I think they need space to be heard, just as the community members and the patients that you see. And I think they need to be involved in the process in a responsible way, to not take over the work, but kind of tell you what they want to see, and then we take it on and do it. Far too often we do these workshops and we do these talks and we do the lectures and then we just go back to regular life and every day. I think choosing to take those tangible action items in the spaces that you're in to actually employ them is going to be the move forward. And that's what students want to see. They want to see the change and what that looks like. I also think getting really innovative. We do some workshops that involve theater play, sometimes in a theater. And we have scenarios that are ripped straight from the headlines. I manage our bias incident reporting tool, have mercy. And so I get to see all the things that our fellow students and colleagues do and say to each other on a regular basis, because that gives us the pulse of what the culture of our college is like. And we rip straight from those headlines and we develop scenarios and we hire actors to come in and replay those things in real time for educational purposes for our faculty, staff, and students. And they get to say, what would you have done if you were the patient? What would you have done if you were the faculty member? And talk through those very tangible things. Students are ready to move from theoretical and philosophical to action, which is why the theater part really works, because it's real, it's tangible, it's what I've seen, it's what I've been through, and in the moment I'm learning how to respond. They also want tools, right? We develop a passport to inclusivity that I call our PTI. If people are into sports, PTI was a show. Anyway, we call it PTI, and it really gives you exact language to say in the moment when particular statements, offenses, and insults are made. And it gives a scenario based on that. And it's small enough to fit into your white coat so that you can pull it out and become handy and really practice interrupting. There's fear that comes along with these very uncomfortable conversations, right? I'm just used to having them. So practice is really about getting used to having them, being open to kind of exploring other ideologies, other values and beliefs, and kind of really taking that in order to engage in those conversations. So more conversations and listening to where they want to take it.
Any other questions? Yeah. All the question, but I don't know if you better caught it, if you want to kind of sum it up.
Correct me if I'm wrong. Depending on the audience, when I talk about anti-racism versus non-racism, depending on the audience, people may say that, what about reverse racism? or reverse discrimination, and how might I handle that and have I encountered it? Absolutely. So, you know, everyone has bias and everyone has privilege. My own ideologies do not ascribe to everyone being racist. Racism is rooted in white supremacy as the foundation of our world and the power structures and authority that has happened based on colonialism, genocide, slavery, and these other things. The generational factor is what everyone else has adopted based on that supremacist nature, and then that became discriminatory. Because racism is about power. It's a power structure. When we look at health disparities, when we look at who runs the world, when we look at people in authority and who have power and decision making, it's really limited in terms of underrepresented people and marginalized and oppressed groups. When have we seen a differently abled president? When have we seen, right? Like we don't see representation of marginalized and oppressed people, which means not only are the voices not present, but the power and authority to make decisions aren't there. So when we talk about racism or reverse racism and discrimination, it's not something that exists. It tends to be a deflection to not have accountability for the perpetuation of the racism that we see in everyday world. And not necessarily because the person doesn't care, but because it feels so big. And I feel personally attacked because, like in American History X, my dad may subscribe to these things. And so when you kind of challenge me on that, you're challenging my father. So it's really rooted in a supremacist ideology, and I tend to engage in those conversations in order to gain the viewpoint and vantage point. But based on the foundational knowledge that we have and the research that's there, I don't ascribe to reverse racism. I do believe that we all have biases and that we can be discriminatory. As a Black woman, I could discriminate on someone else based on a privilege that I hold and a marginalized or oppressed status that they have. But racism is much bigger than that, and it's much more of deep-seated, embedded power structure that it doesn't lend itself to marginalized people.
In the center. So the question is, how can we advocate for patients without kind of falling into the white savior complex or speaking for them?
Ooh, another $1 million question. Y'all did your homework. I love it. So yes, the white savior complex is a thing. It's really about assessing the room, assessing the tone. And I think first, even building relationships with the people that you work with, underrepresented or not, so that you can get to know how they accept feedback or constructive criticism. And ask that person when you see something, right? We say say something, but maybe that person doesn't want you to say something. So maybe you turn to that person in the meeting and say, I felt like that was really rude. I felt that was insensitive. I felt that was sexist. I felt that was racist. Do you mind if I say something? And I think that's with the building of rapport and relationships with individuals. And that's much better than waiting until after the meeting and saying how sorry you are that that just happened to them. And then you see it happening over and over again and nothing ever changes. And that's how we lose people in those spaces and kind of have turnover. But I think it's also about making sure that when you're using your voice that you're not overpowering or overtaking the room, because that's where the white savior complex comes from. It's kind of rooted in, I know so much, I've read all of these books, and I'm an ally and an advocate. And so now I'm gonna spend like 20 or 30 minutes in this staff meeting going on this rant about how much I know about it, right? And so choosing to kind of be self-aware and how much space you're taking up, right? In those rooms is gonna be important to consider. But thank you so much for that question. That's really critical.
Yeah, right here.
Yeah. So unfortunately, you will experience it just as she has. when you do, call me and put them on the phone. I'll tell them about it. No. Um, I tell my students to do that. I'm like, if you don't want to tell your preceptor, then you call me. No. So again, I've been doing it for a really long time, and I'm quite comfortable having uncomfortable conversations because I recognize that it's not about me, that I recognize that there are people that are dying, literally, as a result of the way in which we think about them, right? And so in those moments, I choose to ask questions, right? I wonder if you could tell me more about that. When you said this is how it felt, or this is what I learned about that particular behavior. And it really puts the onus on them to think about the things that are coming out of their mouths that may not be the kindest, that may be insensitive, and that may be rude. And so I really use the question method quite a bit, and it minimizes sometimes, depending on who you're talking to. You're going to believe what you believe and think what you think. It really comes down to the space you're in, and if accountability is going to be present by the people that have the power to hold folks accountable for perpetuating those things. But generally speaking, using the question method, if you feel like you're in a brave space to do so, sometimes talking about these things are not brave, and that they can get really controversial. It can get violent in words and other ways. And so assessing the room to make sure you're in a brave space to really ask them to lean into that. And then that's going to be up to them based on their maturation level. We all know that age ain't nothing but a number. Y'all might not know Aaliyah because I might be aging myself a little bit, but sometimes maturation doesn't necessarily come with age, right? And you might tend to be younger than the people you end up having to engage with in those conversations. And so it's going to be up to them how they take it and accept it. But I found that over time, asking questions and asking people to tell me a little bit more about what they mean by that really helps either opens a dialogue or it shuts them down from saying things like that to you again.
Other questions? Yeah. So the question is, as students, how can they decipher, what is fact and what might be rooted in historical or institutional racism?
I wish I had a cookie to just give people for these good questions. So excellent question, right? So the first rule of thumb is question everything. That's number one. Question everything. Look at the resources that are being used. Are there voices of underrepresented people represented in the work? Sometimes Google is our friend. Sometimes it misleads us. But unfortunately, it will take this individual onus to do some additional homework. And when you hear something that doesn't sound necessarily right, or you just know, like, hey, that is really old practices that's kind of really rooted in sexism and racism, I'm going to go look that up and make sure I'm not going to perpetuate that later. But it's also using that voice as an ally, advocate, co-conspirator, and going to the powers that be, whether it's that faculty member or the leadership, and say, these are the things that we're being taught. I found this other stuff that really says this isn't okay, and we should really be moving away from that. If you have a chief diversity officer, if you have someone kind of leading that charge, sharing that with them so that they can then go and advocate for a change in that space. Because of some things that we were teaching at our medical college, we developed an anti-racist culture committee. And our committee doesn't just focus on race. Because of intersectionality, I don't separate my womanhood from my blackness. I'm one right person. I can't be split in half. And so the anti-racist culture committee addresses sexism in medicine, racism, and so on and so forth, where we actually review what we're teaching in the curriculum. We look at our policies and procedures to assess it for gaps and how we might be perpetuating oppression and marginalizing people. And so I think looking at it with a critical eye, questioning everything, having a conversation with the faculty member. I know that is sometimes scary for students, but I promise you, and they'll agree that they are approachable and they want to engage in those conversations. And so taking it and really saying, I'm not sure if this is accurate. This is something else I found that I think we should be moving into the direction because it might perpetuate this. And as we go on our inclusive journey here, I think it would be important to take a look.
Yeah, in the back. So the question is, in your work, have you come across examples of healthcare systems that are doing this well and have, helped improve health outcomes?
Not yet. Not yet. Not yet. So it just right like this foundational history that we have in the socialization process, all of those things that I named are still perpetuated today, like are really rooted in those ideologies. I think it's going to take a little bit more time for us to fully get there. I think what they are doing well is having conversations about it, right? Getting to know folks and educating students specifically about the fact that Black women are 3 times more likely to die in childbirth. Making that education, figuring out why that's happening, and kind of facing the people in the mirror and like really taking onus and accountability for it. So there's not an area in the healthcare system where I feel like the rates have decreased. Even on the chart you saw from 2006 to 2017, Black women were still the highest that were dying. So for a really long time, this has been happening. What I think is happening in medical education is that it's taking a turn, and that the COCA standards being updated and these other things that are really foundational to the practices. We're hierarchy, right? We're all about following the process and hierarchy. And so I think it's going to take us to continue to make changes in those spaces and areas that trickle down to our educational system and how we're training our physicians. Like, we're responsible for making sure that you're aware of this so that you don't go and commit those same mistakes. So I think that's where the start is. So not yet in terms of really increasing better, but I've seen medical educators do better so that they can train better physicians that are more competent and culturally aware.
Yeah, right here. The question is, how do you respond when your credibility is questioned as a Black woman?
Yeah, so that doesn't happen. What are you talking about? Never, not at all. So a few times I've had conversations with people that told me my research was not what the research was, right? That you're just kind of spewing your opinion despite research conducted and charts and pulling other colleagues in to demonstrate that work. For me, it happens far more often in the classroom than it does anywhere else, where the challenging of authority, because how dare you, Black girl, Black woman, with some of the cultural swag that you may have and bring into spaces, how dare you be the authority of me? I've had a student come up to the podium while I was out of the classroom when they were working on a activity and advance my slides. Like, think about that as a faculty. I know, that was my face. Think about that, right? As a faculty member, the authority in the room, I would have never in the classroom went up, right? Why would you think to do that? Why would you think that was okay? And I came back in and I was like, oh, that's odd. The slide has moved. And she's like, oh yeah, I changed it. We were finished. The gall, the audacity. So I think it's much more subtle, right? So it's being challenged, but it's like in these really subtle ways, like the microaggressions that happen. It's not calling it out in my face and saying, hey, I think your research is right, not up to par, and I think you're not as credible. It's kind of those things in everyday life that happen. Because I've been doing it for a while, I don't internalize it, and it's one of the call to actions in terms on the micro and individual level, not taking it personally, right? Standing in your truth, knowing who you are, operating from the expertise that you have, and doing that question and answer part, right? Like, I wonder why you would do that. Having them really sit into their choices and modeling that accountability is how I tend to approach it. Otherwise, I just ignore them and continue on the good work.
Yeah, right here.
Yeah, that's a good question. So, oh, go ahead.
Yeah, so the question is, when it comes to the issue of Black maternal mortality, have you looked at, their community and society and how that impacts their health outcomes?
Yeah, and that's a really good question. So there are always things that are going to overlap. When we talk about intersectionality, we're talking about overlapping systems of oppression. Environmental factors are going to be one of those things. And environmental meaning pollution, environmental meaning neighborhood, right? And then we go back to the foundation of our world and society. We know that gentrification and changing spaces and environments and cultures that underrepresented people live in happens. We know that there are more bars and liquor stores in urban and Black communities than any other space, and the people that live there did not make those decisions. We know that the historically disadvantaged areas and neighborhood have less access to quality health care, and as a result of poverty do not have medical benefits and insurance that sometimes lend itself to getting the most quality care. And so yes, those things are absolutely factors, and there's still this history of inequities and disparities built into all of those other factors that exist. So it's one of those things like I could choose to go change the environment, I can choose to go change this. And when we look at the length of years and frequency of who's dying more, there's still some other things at play. Good question.
Yeah. Yeah, so what's your advice for opening more hearts and minds for engaging in this work when we talk about privilege?
So I'm totally a heart and mind person. The foundation of who I am is rooted in social work. I have a master's in social work, and I did a lot of grassroots work and counseling for marginalized and vulnerable communities. And this work very much in diversity, equity, and inclusion is about changing hearts and minds, which I told you earlier is hard to do when we've been socialized a particular way. And when we choose to internalize that I am the problem without kind of that culture of humility, changing hearts and minds is a slow process, sometimes agonizing. It's about chipping away at the iceberg, again, because of how deep rooted it is. And no one ever wants to feel bad because we're good people, right? Like no one in here would stand up and say, actually, Tanisha, I'm not a good person. No, we all believe that we are good people, that we come from good places, that we don't perpetuate these things. In reality, we are all good people, and we make mistakes, and we perpetuate these things based on that. So creating spaces where we can have real conversations, that we minimize the discomfort and uncomfortability that we end up feeling, because that's coming from somewhere, right? It's almost like going to therapy. It's like, oh my God, I'm talking about my feelings. And I'm talking about these things that really are rooted in me. And so when you hear things that make you uncomfortable, it's really this internalization process of like, why? Like, and we don't ever sit in that or aren't held accountable for our reactions to things that we're hearing that are different from what we feel like we already know. Or we feel like we're taking it personally and you're talking directly to me. And not just about these disparities that occur. So it's all about changing hearts and minds, and it's about having the conversation, but also giving grace where grace is due. I do not think that combating racism and minimizing Black maternal mortality is going to be taking hands and skipping through flowers and looking at things through rose-colored glasses. And I don't subscribe to cancel culture, right? Because I think it's about education, and I think it's about lived experiences and attempting to meet people where they are. That's social work again, meeting them where they are, and then choosing to enhance and enrich that. That does not mean the toll and the taxes on the marginalized or oppressed group, that you get to come to me to talk about that every time and minimize me. It means doing that work on your own, and it means having brave people that you know are allies and advocates when you're struggling to understand something or really get a good grasp on it, to go to them and have those conversations with them about what you're thinking and what you're feeling and how you can move forward. Those relationships are critical. I wear my story and narrative as a Black girl from the South Side of Chicago, living in poverty, going to historically disadvantaged schools, on my sleeve, because that's important for people to empathize and see me as human. The narrative and personal storytelling is going to be critical to changing those hearts and minds, because then people can see it for more than just these terms that scare us. Then more than just sexism, racism, they call me racist. We can remove that from the table. Let's get to know me and who I am. Let's get exposure to diverse groups of people and know that we're all human, attempting to live a good life until we leave this earth. So changing hearts and minds is what it's all about. Not canceling people because they make a mistake, because we all make the mistakes, right? But it's also taking accountability if you are consistently making the mistakes more than once.
All right. That's all the time we have for questions this morning. Thank you for attending this keynote.
Thank you.
Thank you, Dr. King.
Thank you.
We're going to take a 10-minute break now, and when we come back, we'll have a panel of specialists here in the theater. They'll be diving into health
Thank you. I
disparities,
appreciate that.
humanities, and bioethics. If you have any questions today while you're here, feel free to ask anyone with a volunteer sticker, someone at a welcome table, or anyone with a Viterbo name badge. We'll see you back here in 10. Just wait.
They said we could move around and stand. How do you know that?
Because I can hear your echo in the auditorium. Oh, there's Joe. I did. Yep. I had Dr. King's. Check, check. There we go. Turn it off now. And
Are you supposed to turn it off? Are we supposed to? Okay,
They can also mute you
okay,
if you don't want to mess with it.
all right, check. Check, check. Mine, it is. I think we're, they said it. So you're just gonna get.
Check, check. 1, 2. Testing, testing. Oh, is that me? Hello? Testing, testing. It's not very loud. Oh, okay.
Check, check.
Hello? Hello? Hi, welcome back, everyone. Can you hear me? No? Maybe this- Hello? All right. All right, welcome back, everyone. Next, we're going to learn more about health disparities, humanities, and bioethics. But before we dive in, we're going to hear from a student here at Viterbo University about why this topic is important. Please welcome Jerica Mueller.
Hi, everyone. As Hope said, my name is Jerica Mueller, and I'm a sophomore biology major here at Viterbo. I'm looking to go to medical school after graduation, so this symposium really hits home for me. I chose Viterbo for a variety of reasons, some of the most prominent being the small class sizes, my ability to be involved in both clubs and sports here on campus, and the excellent location, as I'm sure you all are aware. However, what I have discovered here over the last year are more friendship, knowledge, and joys than what I ever could have imagined. For example, at last spring's Science Symposium, I got to meet the Erin Brockovich, who, if you don't know who that is, you have to look her up and watch her movie. It's fantastic. Beyond that, the symposium also made the details that I had learned about environmental hazards in my general biology class more applicable to local areas. Connections such as this have been super important to bringing value to what I am studying and to keeping me engaged in my major. Another one of my most influential experiences was through the summer research project that I conducted a few months ago. The wonderful honors program coordinator, who was here earlier, Dr. Matthew Bersiegel-Braley, invited me to jump on his research project studying how certified nursing assistants coped with and overcame the changing and challenging aspects of their work during the COVID-19 pandemic. Our team conducted many hours of qualitative interviews with CNAs from Midwest, Southeast, and Atlantic regions of the United States. The stories that I heard in these interviews were littered with more challenges, harassment, and discrimination than what I ever could have imagined. Yet, all of our over 20 participants found passion and purpose in their grueling work. These stories of triumph were surprising and enlightening for me, and they taught me to understand that there is value and worth in every person and their experiences, a sentiment that I hope to take with me in my long-term medical career. That being said, I want to say thank you to all the healthcare workers and students in this room and all over the world who do their best to provide equitable and holistic care to those who need it most. You are so appreciated. This symposium, too, has and will be another great opportunity for me and for all of you to make connections between our education and the world around us. I hope that as the day continues, you can keep finding ways to apply this knowledge to your studies, your jobs, and your lives. Thank you.
All right, thank you so much, Jerica. Now I'd like to introduce our panelists. Sandy Brekke is a senior consultant for the Office of Population Health at Gunderson Health System. Population health uses research and data to understand the interrelated conditions and factors that influence the health of populations over the life course. Sandy is actively involved in several local and state initiatives addressing health equity. Brenda Rooney is an epidemiologist at the Office of Population Health at Gunderson. She received her master's and doctorate degrees from the University of Minnesota. In her more than 30 years at Gunderson, Dr. Rooney has developed programs and initiatives that focus on chronic disease prevention and has developed population health dashboards. And Tom Harter is the director of the Department of Bioethics and Humanities at Gunderson Health System. He received his PhD in philosophy from the University of Tennessee, specializing in medical ethics and business ethics. Dr. Harter's research on ethical issues at the intersection of business, medical professionalism, and patient care have resulted in numerous peer-reviewed conference presentations and articles. Thank you so much.
Well, hello. Working okay? So the panel thought it would be best for us to start with some definitions just to kind of ground us all. I should stop and say I'm honored to be here today, and I'm glad that you guys are all here. And this is the first time I've been in a room with more than about 5 people, so in about 2.5 years. So, okay, so if I'm a little anxious, that's why. All right, so some definitions to kind of ground us. The first, kind of the equality and equity terms, I think we throw those around and we don't necessarily always think about what they mean, but equality means that we're treating everyone the same, right? And that we all want equality. We all want a chance to be equal and be seen the same and given the same resources. But equity really looks at whether or not people need in different circumstances need more so that they can achieve equal outcomes. So that's a different way to think about things. And when it comes to health equity, we really look at health outcomes and say, are all of our people in our community and that we take care of achieving similar health outcomes? Then health disparity is really when we see that they're not, and there's this disparity. And I'm going to show some disparities, some local, to kind of give us a little bit of a wake-up call that these things are happening here in Western Wisconsin. And then did want to just briefly mention historically excluded populations. So I think we think a lot about, oops, I can't go back to that. Okay, we think about people of color, we think about people with disabilities, people who maybe women or ageism. The physical disability piece is a real important thing, I think, as we think about things, especially things like mental health conditions. If you have a mental health condition, does that get you the same kind of treatment? If you come in with signs and symptoms, is your provider gonna assume that it's because you have a mental health condition or because you have a real symptom? So I think these are all things that you need to think about and ways that we can think about healthcare disparities. When I first started here 30 years ago, I came to La Crosse to do research, and part of the appeal for me to do research here was that people were born here, they lived here all their life, and they died here. And it really provided a great way to do this longitudinal historic research on a very homogeneous population. And 30 years ago, we were 97% white. That was our reality. So that was really true. So the first half of my career really doing research here, I don't think I even ever looked at race as a variable because it really didn't play a part. But the last 15 years, I've really started to peel back some of the layers of the onion, and try to understand race as a demographic and also other variables, and I'll show you some of those. And we are no longer 97% white. We are now about 92% white, but we're also very rural. We're very, some poverty is high. There's a lot of different ways that we can look at people, and I think there's 1,000 different ways that we can look at our population, not one way or two ways to look at our population. So just to give you some, the first wake-up call is this is mortality for Western Wisconsin. So these are the counties in Western Wisconsin that Gunderson has patients and we consider our service area. And this is looking at mortality. So are people of color dying at a higher rate than our white patient, or people. This is people. This isn't patients, these are people. And the first thing you see is that our American Indian population is dying at a higher mortality rate when you age adjust. So if you just go out and look at the total number of deaths, you won't see a lot of deaths in non-white people because, again, we're 92% white. But when you actually look at who died, how old they are, premature mortality is much higher in our American Indian population, not as high in our other Hispanic Black population. So that's the first thing. The second thing is just to tie back to the keynote speaker today, Dr. King. I wanted to look at maternal mortality in our area to see if we had a disparity similar to what she was showing nationally. And fortunately for Western Wisconsin, we have very few deaths for mothers during childbirth. It doesn't happen very often. So it's not a really good measure for us to be able to look at unless we pile, like combine 15 to 20 years of data, and then it really isn't very meaningful. But I did look at measures that I could look at around pregnancy that are not death. And so I looked at preterm delivery, low birth weight, and teen birth. So these are all things around pregnancy to see if we have disparities in our region regarding that. And if you are non-white, you have a higher preterm delivery rate, a higher low birth rate, and a higher teen birth rate. This is combining 3 years of data. And preterm wasn't significant, but low birth weight was. So low birth weight, so babies born of non-white women have lower birth weight, and that leads to potentially a lifetime of less health, fewer or more health consequences. I did want to dig deeper because when we aggregate data, we lose some of the wealth of information. So I tried to disaggregate this. So I combined either preterm or low birth weight. Both of those would be bad outcomes for pregnancy, and then was able to kind of break it out by different racial groups. And we saw 1 in 4 Native American Indian population births at our facility were either low birth weight or preterm, and 1 in 5 Black women, low birth weight or preterm, compared to 12%, 14%. So clearly there is a disparity for birth. All right, so I'm going to try to show you some differences also in equality versus equity with data. And let me just explain this chart. So this is data from pre-pandemic. So first of all, this is 2018 data, but it was aggregated by a Wisconsin Collaborative for Healthcare Quality and then sent back to us. And since then, I'm actually doing a lot of this work actively with our data, but this was aggregated by someone else to share with us. And this is looking at optimal testing. So this is optimal testing for patients with diabetes. So did we as healthcare providers do the right testing for our patients with diabetes? And there's 3 tests that they're supposed to do. And this is looking at percent that had these tests, if they have diabetes, by race, by payer, and by living location. So just a minute about living location. We're looking at rural and urban areas in our service area, and this is actually across the state as well. And then furthermore, we're looking, rural and urban don't look the same because La Crosse is urban, but we don't look at all like Milwaukee, right? We're very different than Milwaukee or Green Bay or those places. So there's urban advantaged, there's urban underserved, there's rural underserved, rural and rural advantaged. And this advantaged versus underserved relates to how many healthcare providers are in your zip code, how many, what your education level is, what your insurance level is, and a few other measures like that. The point to this slide is that if you look at whether or not we're delivering services, doing the tests that we're supposed to be doing across the board, it's not bad. It's not bad. And most people, I think, that look at this would say, well, it's not bad. Our Black population, not as good as the rest of our population. But when you actually get to the nuts and bolts of this, this is maybe 100 patients. So that might be 40 patients. So the numbers are small. But as far as are we delivering care across the board equally in this measure, it doesn't look bad. But when you look at the outcomes of these patients, this is optimal control of their diabetes. So this looks at, is their hemoglobin A1C, their measure of long-term, or fairly long-term control of diabetes, is it optimal? Is it where we want it to be? And here we really see, sorry, could you go back? We really see a difference by race, where 52% of our white patients are at optimal control, but only 32% of our Black and only 29% of our American Indians are at optimal control. So maybe treating them the same isn't enough, and maybe we need to be thinking about what more do they need? What more can we offer them to get their control up? And I think where our minds land in healthcare is that every day we come to work to do the best thing we can. I don't think we think consciously about this person is on Medicaid and they're not going to follow my advice anyway, so I'm not going to do these things. So we tend to dismiss, because we can control our actions, we tend to dismiss these differences that exist, and conscious or unconscious. So this is a picture. I'm sure there are thousands of pictures out to describe it, but every patient has barriers. It's just that some patients have more barriers. So this is really a measure of, this shows equity. What do we need to do to get everybody to the finish line at the same time, or to get them to the finish line? This is one more example, and this one really, I think, is a wake-up call for healthcare, which is this we own. So like I said, we like to sometimes dismiss it on the patient isn't following what we're wanting them to do. The patient wouldn't pay for this anyway. We like to blame the patient because we like to think we're delivering the best care we can. But this is an example of whether or not we screened for depression. It's a piece of paper or a computer where people fill out when they're at their exam, did we screen them for depression? And these are all people who had appointments in the same time frame, the same number of appointments. So it's not like they weren't coming to the healthcare system. And here's where we see, no, we're not screening every patient for depression. It's only 62% of our Hispanic patients were screened for depression. And if you have Medicaid or no insurance, you're not, you're even less likely to be screened for depression. And that makes me wonder, or makes us wonder why. Is it that we just don't want to screen our Hispanic patients, or are there some reasons for that? And so I have 2 slides left. One is to talk about what some of those patient possible causes are, some of the root cause stuff that makes us want to know more, and some is on the healthcare side. So one is that there might be significant language barriers. So the Hispanic, we're not screened for depression. Maybe that's because they don't speak English. And if our survey is only in English, they wouldn't be screened. Is that an issue? Well, our survey isn't only in English, but maybe we only screen when they come in for a wellness appointment and they're not coming in for wellness appointments. There's just, all of these different reasons. But people don't necessarily read English. People don't always speak English. Do we have things translated in a culturally competent way? Health literacy, medical terminology is so complicated. Do patients know when we say you need to be screened for colorectal cancer, what that means? What does that mean? What matters to me as a patient too? I think that is so important, and a lot of times we don't know that because we're treating, in a day, a healthcare provider might be seeing, 15 patients. Do they know that patient? How well do they know that patient? And what matters to them? Maybe they really want to get to their son or daughter's wedding, and maybe they don't necessarily want to know about their A1C. What matters to them is that they can walk down the aisle. So I think that's important. Culturally, some cultures prefer less invasive healthcare, and not everyone wants to have a colonoscopy. So, are there ways that we can find less invasive care for them? Fear of diagnosis. We hear this all the time. People don't want to be screened for cancer because if they have cancer, they don't want to know. Likewise, if they are, like when we're screening for lung cancer, a lot of patients say, I don't want to be screened for lung cancer. Number one, if I have it, I'm going to die, and I don't want to know that. I'd rather just go on living like this. And the other is stigma. If I have lung cancer, it's because I smoked and I brought it on myself. And so some of those things go into it. There's this general distrust in healthcare and in doctors that I think we really have to address. And then, there's lots of life issues. COVID happened, people lost their jobs. People can't afford to put food on the table. And now we're going to tell them that they need to take this expensive drug. It's this thing that we have to balance. how to get screened, how to make an appointment. All of that is very complicated. And I put non-compliance on here. My list just keeps getting longer and longer every day. But non-compliance used to be, I think, the term we used. This would have been one bullet. It said non-compliance. All of these reasons are why a patient might not comply with what we want them to do, but that's not non-compliance. And I don't like to ever see that term in a chart review that this patient was non-compliant, because it's so much more than that. And then from a health system perspective, I talked a little bit about some of these, but when a patient comes in dealing with pain or hypertension and they need a blood pressure check, it's pretty hard to say, oh, while you're here, let's schedule your colonoscopy. It's just not always the right time, and you have to sometimes deal with the problem that's the most pressing on that patient today. Our appointments are not always available at convenient times, and if you think about healthcare and how we've changed over the last 30 years, one thing that hasn't changed is our availability of appointments from 8 until 5, Monday through Friday. And what does that do for people who work nights or work and can't get off work? Our schedule is complicated. We have unconscious bias, as Dr. King mentioned today. We don't want to have unconscious bias, but we do. It's our brain and the way our brain has really simplified and helped us to get through every day. But we have to understand it and know how to react to it differently. And then again, what matters to the patient and what matters to us are not always the same. We want this patient to be screened so we can check the box and move on to the next patient, but that patient might not have similar goals. So it's really important for us to understand these things. And I can say at Gunderson, we are really starting to look at these issues and try to peel back the onion on different issues and try to understand how to address some of these issues more with our patients. All right, so Sandy, you're next.
Thank you. I love Dr. Rooney's data. For the most part, because it tells a story of what's happening now, but it also provides direction to where we need to go. How do we change Dr. Rooney's data? That's always my goal working in population health, is how do I take what Dr. Rooney is showing me and make some changes to it? And she talked about some causes for some of the disparities that might be in the realm of what a health system can control. But what are the other causes? And I think that's where I spend a lot of my time thinking, actually some nights thinking, in the middle of the night thinking about what are causing these health disparities. Just a minute about me. So I'm a nurse, and I have worked with the underserved for pretty much my whole career in medicine. I was director of a free clinic. So at free clinics, we see people who are uninsured and really don't have access to health systems. And one of the things that bothered me was, at this free clinic, our clinicians and nurses all came from the big health systems. Our care was free. We had access to labs and tests, and we had access to the systems. We even provided free medications for our patients. And we still weren't coming close to health outcomes. And I used to sit 25 years ago and think about why. Why is this happening? And it really started this journey. Where does health come from? And so this is the county health ranking and roadmap, we'll say chart, as to where does health come from. And so if you look at the top, we're looking at longevity and quality of life. And the items on the right there are the factors that actually lead to those health outcomes. And so what this does is it gives us a percentage of the factors that go into our health outcomes. So if you look here, the one that's circled now, clinical care. And what we know is that clinical care really has a very small impact over our longevity and our quality of life. Absolutely critical that we have access to high quality care when we need it. But it's really not a driving factor in our health outcomes. Nevertheless, I think, and we've heard a lot of this today, it is really important in healthcare that we understand the harmful effects that we've had in the past. It is also absolutely critical that we address the systemic issues that we have going on with power dynamics in our health system as we move forward if we are going to really get to equity. So this group that's circled here, this is the meat. This is where health outcomes are coming from. And these are called the social determinants of health. So the social determinants of health are where we live, work, play, age, learn. It's where we spend our time. It's where health is. It's in the community. And so if we look at these factors, education, employment, income, family and social support, community safety, what's our physical environment? So clean water, clean air, our built environment. These are the things that impact our health. And if you look, so let's start at education really quick. So what do we know by looking at the data? So if I graduated from high school and someone over here did not graduate from high school, my life expectancy is probably 12 years longer than that person. If I go on to college and they still haven't graduated high school, those numbers go even higher. And those are growing, we are seeing growing disparity in life expectancy based on education. And so we talked earlier about what's happening in education. What are the systems at play, the oppressive systems? What are the resources that are going into education? Education is critical. And I would argue if we can do one thing is we look at education and we build that system up. Our schools are the mirror to our community's health. And what happens there is predictive with health outcomes. Third grade test reading scores are predictive of who will graduate. And there are studies that show that on the very first day of kindergarten, the kindergarten teacher is the most predictive person as to who will and will not graduate from high school. So these are things we know. So if we're looking to improve health outcomes, where do we go? We need to know what our teachers know. And even before that, where are our birth to 3 and birth to 4, where we should be putting super intense resources, and we're going to see the results 50, 60, 70 years down the road. And, so when we look at that, employment, what our education is going to determine our employment. So those of us that have higher levels of education, we have employment that offers benefits. We have wellness programs. We have good income. We have all of those things that allow us to be healthy. Income, poverty. We know the effects that poverty has, in particular on children that live and grow up in poverty. Family and social support, critical. And we are really just starting to understand what that social support looks like and how critical it is to somebody's health. We talk about loneliness and isolation. These are critical factors leading to our health outcomes. And community safety. I know when I was at the Sinclair Health Mission working with people, we'd want to get people on exercise programs, and we'd say, if you could just walk half an hour a day. And what we would hear is, not in my neighborhood. Like, I will not go out all by myself as a woman in my neighborhood and exercise. These things are critical to health, and these are things that we all need to be thinking about. And when we look at physical environment, things like environmental quality, so climate change, who's it affecting? So it is our people that are on the margins who are going to be most affected and are being most affected. If we look at Katrina and what happened in Houston, who are the people who are most affected and whose health is most affected? Like, we are headed into things that we need to be prepared for in healthcare, because this stuff is really highlighting the inequities that we have, not just in healthcare, but in our whole society. Our built environment. So, we heard about this from Dr. King earlier. What about our neighborhoods? We know about redlining. We know about housing. We know from neighborhood to neighborhood in the city of Chicago, there's a 31-year longevity difference. So someone in one neighborhood may live 31 years longer than a person in another neighborhood if they stayed in those neighborhoods their whole lives. This is significant stuff. So in healthcare, if we're talking about looking at our health outcomes, where do we need to go? We need to be looking at our communities. We need to be figuring out how we partner with communities and how we're going to change some of these things. Health behaviors. So these are things like, do we smoke? Do we exercise? What's our eating like? Alcohol and drug use. These are things like our sexual activities. These have a huge impact on our health outcomes. And what I will say is I think we need to step back and be careful because this shows privilege. I have the privilege of taking care of myself. I have the privilege of joining a gym. I have the privilege of buying healthy foods. I know I'm not supposed to smoke, and I never knew anybody in my family that actually smoked. So health behaviors are absolutely critical. And as healthcare providers, we have to step back and realize our privilege when we're working with our patients and their health behaviors. So one thing I want to add is that a lot of talk now is going on about trauma as being one of the social determinants of health. So we didn't see it before from the county health rankings, but there is serious consideration about trauma as being a determination of health. And we understand more and more every day about the biology of trauma. In fact, there was the Adverse Child Experience Study was a study that was done between Kaiser Permanente and the CDC. And what they did is they looked at traumatic experiences that a person had experienced as a child. So these are things like abuse, neglect, whether we lived in a household with a parent that might struggle with substance use disorder or mental health, or a parent in jail. And they looked at all of these things that children were experiencing, and then they compared them to health outcomes down the road. And what they found are kids that had the more traumatic experiences that they had, the more illness they had as adults. And so why is this? This is the biology of trauma. We know what is happening now in the body when it is constantly exposed to trauma. We have hormones and we have adrenaline running through the body. It affects our immune system. There are all sorts of implications to trauma. And we need to be thinking about this more and more as communities, in part because there's many who will argue, and I would agree, that race is an ace. And we heard about it before. So there is racial trauma that has implications in someone's health outcomes. It is one of the factors, and we need to be looking at this, and we need to be learning about this, and we definitely need to be addressing this. And we need to be celebrating the resilience and the strength of people who have been on the margins for many, many years, and learn from them and include them in our solutions. These are, it is, been way too long that we have been sitting at the table of privilege, and we need to be stepping back, and we need to be pulling those voices in to teach us, what are we doing? How do we do this differently? Just one more time, definition of health equity. And the reason I'm putting this up there is because what we know is these are avoidable, absolutely avoidable factors that are leading to poor health outcomes and disparities, which then offers us tons of opportunity. And that's part of what this conference is today, is we're going to hear some of the local things that are going on that are addressing inequities. And so, and things start at the ground, and these ground swells from each and every one of us as individuals are what is going to change these health disparities. I have the opportunity to work at the state level. I've been on the governor's task force for health equity. There's great things going on. The time is now. I've been in healthcare for many years now, and now is the time. We're feeling it more than ever. I think it's coming from our younger generation, teaching some of us older people where we need to be going, where we need to be putting our energy, and how we're going to change this stuff. I put this slide up there because, in part, to me, it shows some hope. Actually, Milwaukee, the city of Milwaukee, and Lillian Payne, I'll call her out, drove Milwaukee to be the very first city in the nation to declare racism a public health crisis. And with that comes resources, it comes time and talent and energy looking at these health disparities. And I'm happy to say in La Crosse last year, Our county board also declared racism as a public health crisis. This helps draw our attention. It helps draw our energy. It reminds us every single day that we have work to do. This is critically important work, and we need to be moving it forward as we move forward with health in our communities. And so I will now turn it over to Dr. Harter to talk about the ethics and the why. Why should we do this? Why should we care?
Why should we give a damn, as I would put it? So, this is a real treat to be here. Thank you. But the irony does not escape me. I am a cisgendered, heterosexual white male. I've never known what it is like to be in poverty. I have never woken up in the morning without food. I have never gone to school afraid that I would get into a war with another faction of students. I've never worried about having resources for textbooks, clothing, etc. My ACE score is a 1. It's ironic that I'm here to talk to you about morality and health disparities. But it is important, as Dr. King points out, in terms of allyship. So let me tell you about a different Thomas, not Thomas Harter. Let me tell you about Dr. Thomas Leviste. Dr. Leviste is the dean of the public school, the dean of the School of Public Health and Topical Medicine at Tulane University. Very intelligent, articulate speaker. And he starts out a presentation on health disparities, and he says, I am educated from Johns Hopkins. He was born in the Bronx, moved when he was a child to Baltimore, went to Johns Hopkins, went to Michigan. And he starts out his presentation, he says, by virtue of being born in the Bronx, my life expectancy is 7 to 15 years younger than every single white person in this room. It's kind of a stark moment to hear. And it's true. Dr. King works in Ohio. I was at Cleveland Clinic as a fellow. The people who work at Cleveland Clinic, and a mile down the road is Case Western Reserve University and University Hospitals. 1 mile. The people who work in those two places live about often 5 miles southeast in Shaker Heights. Cleveland Clinic is like a Taj Mahal. It's this beautiful health system, absolutely gorgeous, surrounded by desolation, a bygone era of textile mills that have shut down, poverty, and a large Black population. The difference in life expectancy between the neighborhood on the other side of the street from Cleveland Clinic, 20 feet. Life expectancy difference between that neighborhood and the people in Shaker Heights, 20 years. 20 years. 5 miles. It's ridiculous, and it's palpable. So why, here in La Crosse, should you give a damn? This is why. We're going to talk about why health disparities, the mere existence of health disparities, is immoral. You know the data, you know the how. Now you're going to learn the why. We're going to talk about 2 factually verifiable claims. You don't believe me? That's why some of you all have your tablets and you're looking on Google. That's good. The U.S. is affluent. We know this. We're one of the wealthiest countries in the world. And yet, we have people in Cleveland who are dying 20 years sooner than people who live 5 miles away from them. That's a problem. And we know that health disparities are the result of social structures, laws, policies. These didn't happen by accident. It is systematic. It's not like we woke up one day and went, oh my goodness, people are unequal and there's problems. No, it happened over time by virtue of the laws and policies we put in place. So an example here. with Medicaid recipients. There's work reporting requirements. Why are there work reporting requirements for people receiving public assistance on Medicaid? Well, one of the reasons is that a large number of those individuals are part of what is considered the urban poor. The urban poor was a euphemism for inner city Black persons who were assumed lazy. They don't want to work. Right? It's in some sense, that's explicit, but also implicit bias and racism. It's an uncomfortable truth, but get comfortable with being uncomfortable. It is immoral to impose injustices on others based on race, ethnicity, and social class. Right? The data that we are seeing with the preterm mortality and the mortality rates of African American women is true, but we also know that there's other kinds of data with respect to just women, right? And women at a higher rate than men are disbelieved when they show up to the ER with symptoms, right? That they're more likely to be told the symptoms are in their head than they are to be believed and tested. That's BS. Social contract theory. John Rawls, if any of you have ever read or know anything about John Rawls, this is probably the most common form of how we think about justice now within the world, but particularly in the United States. Thinking about moral theory as an applicable thing, we talk about social contract theory. And the idea here is that justice and fairness go hand in hand, and that what you put into the system, you're entitled to coming out, right? And so we accept the fact that we pay taxes, for example, because we anticipate a benefit that comes from that. Well, what happens if you're doing all those things and building into the system, but you're not a recipient? That's a problem. That violates notions of justice, right? Health disparities subject persons to worse health outcomes, yet they are still expected to pay taxes, right? People who are working are expected to build into the system, yet the benefit is lacking. Deontology, Kantian ethics. I know you weren't expecting me to go all philosophy on you. You did hear I was a philosophy major, right? That was PhDs in philosophy. So a little bit here. Deontology, you all know this already, right? You just might not recognize the word. Deontology, Kantian ethics, is the idea that the moral worth of an action is determined by your motive for the action. Okay, so what you are intending the outcome to be, right? That's what determines whether it's moral. And the idea here is that all persons, under Kantian ethics especially, all persons have inherent moral dignity and worth and value. Where else did you hear something like that? Well, there's religious connotation all over the place with this, right? You think about Christianity, the idea that people have inherent moral value and worth. So what happens when people are treated differently based on race, social class, etc.? It is a failure to respect the inherent value and dignity of the individual person. It's immoral. But if you don't buy that, fine, we can go with utilitarianism. Another deeply rooted moral theory. And some of you go, I don't know what the heck utilitarianism is. That's fine too. That one's just well, it's not quite the opposite, but it's close enough. The ethics and morality of an action is determined by the consequences of the action. Not by the motive, but by the outcome. Fine. You don't like Kantian? Most of you are going to buy utilitarianism, right? The needs of the many outweigh the needs of the one or the few, as the Spock mantra might be for those of you who are Star Trek fans. Health disparities, and this is why when Dr. King talks about this point and the question comes up around reverse racism, I have never in my life been negatively affected, ever, by building somebody else up. And it will never happen. I will never know what it is like to experience health disparities to the same degree, really at all, period, but especially to the same degree as others who experience systematic racism and sexism on a regular basis. I will never be reversely discriminated against in a realistic, plausible manner. The existence of health disparities does not improve good outcomes of anyone. But the fact that health disparities exist do negatively impact the majority. All of us in this room, we build into the systems, right? We have to put in more resources to fix the crap that happened before. That's okay, but we got to do it. And that's a resource burden. And of course, as well as minority populations, we know that. We know the how. We know the data. So just the mere existence of health disparities fails the benefit burden test under utilitarianism. So what are the obligations? So we know, okay, they're immoral, fine. I get it. You might not buy it, whatever. You're wrong. What do you got to do about it? What does that mean for me? What does it mean for us? What does it mean for you? Because you're coming into this world. You're coming into this system. You're going to be providing health care. That matters. You have power. Not a lot, but you have some. At the meso-organizational level, at the societal level, at the individual level. Health disparities in the United States perpetuate pre-existing racist and classist inequities, sexist inequities for vulnerable members of our society. You can just talk with Sandy about any of the things that go on down at Huska Park. You can talk with Molly and Sarah about this. Right? The mere existence of these things puts vulnerable members of society in worse position. And given that there is a constitutional right that has not been applied equally, I acknowledge that, but there is a constitutional guaranteed right to life, liberty, and pursuit of happiness for all US citizens. And so health disparities threaten that. They threaten this fundamental right. You don't even have to make the jump to say there's a right to health care. You can make that argument, but you don't have to for this. Just the mere existence of the health disparity violates that constitutional notion that there is a right to life, liberty, and the pursuit of happiness. And rights and duties correspond. For any right that an individual has, there is a corresponding duty. Somebody has an obligation to fulfill that. You say, I have a right to X. That means somebody else has the burden to fulfill that right for you, to guarantee that that right is considered an entitlement. This is why voter restriction laws are problematic, because it burdens one's access to a right. So certainly individuals should advocate and participate, right? And they should avoid perpetuating, right? So they should certainly be non, but you also need to be anti. And that's hard to do as an individual, but as individuals within organizations, you will, within your organizations, eventually work your way up into having some power. What are you going to do with it? What are you going to do with it? You're going to stew in your own privilege because it doesn't matter? Or are you going to actually take to heart some of these things and go, you know what, this is a problem, and I am responsible for it? Those with power have a stronger obligation because they are in a better position to fulfill that duty. And it is necessary to ensure through laws, policies, things that codify those rights that individuals have as obligations and duties. So that's it for me. Appreciate your time. 10 minutes, had to make a really broad sweeping argument. I hope it worked. And if it didn't, you can come talk to me after and I'll tell you why you're wrong.
All right, let's thank all of our panelists from today. All right, we have just a few minutes left for questions, so I will just follow a similar format to earlier this morning. Just raise your hand if you have a question, and let us know who on the panel, if you have someone in mind for your question. And I'll repeat them for our panelists. So, anyone want to go first? All right, I'll kick us off unless anyone has.
Clearly, I was right. Thank you.
All right. Well, I had a question. Sandy, you know, your presentation talked a lot about how so much of health outcomes centers around outside of healthcare. And I wonder if you want to talk about how, you know, how we get buy-in from elected officials, from employers, business owners, housing developers, et cetera, to kind of pay attention to these gaps.
We get buy-in. You know, I think to get buy-in, number one, you start with data like Dr. Rooney has, because, you know, to set the stage for change, we have to understand what's happening in the first place. And it's really critical that we be looking at data, looking at health disparities data, to be able to tell that story. You know, I think that telling the story is one of the things that can be hugely impactful as we move forward. And we need to get the ear of the people that have the power and can make those choices to us. And I often think we actually have it. Part of what we end up, you know, running into is that, like, how do we change it? It's really hard. Like you know, so you had mentioned Huska Park, and you know, one of the things that I do is I work with Dr. Sarah, and we do a street medicine team. You know, so homelessness, like let's look at homelessness, and let's look at the health outcomes of people who are homeless. Average life expectancy in La Crosse, if you are a chronically homeless man, is 52 years. How do we change that? But talking about that story, presenting that data, and showing how it impacts, like you said, how does that impact me? Like maybe I don't care about homeless actually. How does it impact how I feel about humanity and what is right and what is wrong? And if you don't care about that, I can show you a lot of data that shows it's way more expensive to keep somebody homeless than it is to have somebody housed. And these are the stories, and this is the data, and these are the things that we have to really rise up and elevate up. And we have to reach out. We have to be reaching out to the people who can make decisions and making sure that they're listening loud and clear. The other thing that's critical is my voice means something, but I can tell you this, I sit with people who are experiencing homelessness, and they join us at these meetings. Their voice is who we need to be listening to. They have the story, they have the criticality. They can explain like I'll never be able to explain. And so someone like me needs to take a step back and help elevate the voice that really needs to be heard, that's really going to make the impact.
Other questions for our panelists? Yeah, over here. Yeah, so the question is, you know, how do we use both, you know, how do we get good data that doesn't obscure, you know, populations that are smaller within the broader community, but also, you know, incorporating individual stories? How do we, you know, kind of marry those two together as we look at these issues? I don't know if anyone has thoughts. Brenda?
Yeah, I can start with that. You know, I think in part we have stories, we just haven't tried, because they're one story out of 100, we haven't listened always to those stories. And maybe we're also not as open to accepting those stories or asking people to share their stories with us. I think you'll see a change in healthcare in the next several years around really trying to understand better who the patient is and what matters to them, because I think that is the direction that we're going to move. How do you take that information about what matters to me, Brenda Rooney, what matters to me today? How does that get communicated to hundreds of clinicians potentially? We have, technology can do that. So that's one thing. I think we do have stories, we just haven't been open to pulling them out and listening to them. And then it's really about trying to engage traditionally marginalized patient groups and put them on panels and put them in focus groups and family advisory councils to help us solve problems, to really listen to the voice at those tables.
All right. Unfortunately, that's all the time we have for questions today. We'd like to invite all of you to join us in the FSPA lobby and outside for booths on organizations that are working on health equity. Those include a book signing by Dr. Tanisha King, La Crosse County Veterans Service Office, Hope Restores, Tri Beta Honor Society of Viterbo University, Counselor Education Department at Viterbo University, Quantum Group Financial, and Disability Consulting. If you ordered a lunch, those will be on the west side of the FSPA lobby for $15. You'll also find a networking area and a photo booth in the lobby. After this break, starting at 12:20, we have 2 rounds of breakout sessions that will dive into additional health equity gaps. The list of breakout sessions and their locations are on the screens and on the posters in the FSPA lobby. As a reminder, if you have any questions while you're here, feel free to ask anyone with a volunteer sticker, anyone at a welcome table, or with a Viterbo name tag. Thank you again for joining us today. We look forward to seeing you at next year's symposium.